Welcome back to In the ED Now podcast to make you an excellent emergency department physical therapist. I'm your host, Dr. Rebecca Griffith, the ED DPT. And we're really excited today to have a different type of guest with us today. In the past, we've mostly interviewed other EDPTs and maybe some physicians, but today we have Dr. Sarah Steely Wright, who is an ED pharmacist. Welcome to the show.
Thank you so much. I'm excited to be here today.
I'm thrilled to learn from you. So, why don't you tell everybody a little bit about your background and also if you could just include what it takes to become an ED pharmacist? I think we just don't know.
Yeah, absolutely. So I attended Harding University in Searcy, Arkansas for my undergrad and my pharmacy school. I graduated from pharmacy school in 2021. And so pharmacy actually has residency programs that you can do. There's PGY1 and PGY2 residencies. PGY1s are generally a little bit more general, so just clinical pharmacy on a more general basis. And then PGY2s are typically specialized. So there's different pharmacy specialties like infectious disease, emergency medicine, critical care. So lots of different PGY2 opportunities. So I did my PGY1 at St. Bernard's Medical Center in Jonesboro, Arkansas.
Who
And
has
then
the first emergency department physical therapist in the state.
they do, super proud of. And so after that, I considered doing a PGY2, but there were actually no pharmacy PGY2s in emergency medicine in Arkansas. And so, because of that, and wanting to stay close to my now husband and his family, I took a bit of a non traditional path. And so, after residency, I stayed on at St. Bernard's and I did a little bit of a mix of everything. I did some critical care pharmacy. I would round with our internal medicine residents. And then I helped piloting the expansion of their emergency medicine pharmacist hours. So at the time, their emergency medicine pharmacist program, they only had one. It was 8 to 4:30, Monday through Friday. And so I helped pilot that more into the evening hours and documented interventions that I made and eventually helped get approval for a second FTE for an emergency medicine pharmacist there. So that was wonderful. And then, let's see, beginning of 2020, I had the opportunity to make the transition to Baptist Health North Little Rock full time in the emergency department there. Got to move a little bit closer to my husband. So that was very good, very needed. We had been doing long distance for a while and that was getting old. So I've been here at Baptist for 1.5 years now. And I still work at St. Bernard's occasionally in the emergency department, filling in when their emergency medicine pharmacists are on vacation. So really enjoy getting to still go and see my friends up there. And for pharmacy, getting to where I am, pharmacy also has specialty boards that you can take.
Good.
So I am a board certified pharmacotherapy specialist. I took that exam in 2022 after I finished my PGY1 residency. And then I am actually getting ready to take my emergency medicine pharmacist boards next week. So been very busy studying lately and excited for that and hoping that it goes well.
Well, that does sound like a lot. And physical therapists are somewhat similar, right? We can do residencies and fellowships and different board certifications. So it's really cool to hear that pharmacists are doing that same type of thing. And it sounds like it was a really intense process to get you where you are. My first question for you is about best way. I guess I'm going to back it up. I want to start with what do you do on a daily basis in the emergency
Yeah.
department? Because I think that'll maybe help people understand how they can collaborate with you better.
Absolutely. So every morning I come in, I look over what all patients we have in the emergency department and just determine where I need to start my day from there. I'm very hands on in bedside emergencies, so acute resuscitation, cardiac arrest. I'm there preparing medications at the bedside and making recommendations about medications to give during a code. Strokes, I'm right there in the CT scanner with the neurologist assessing for contraindications to thrombolytics. And then if thrombolytics are indicated, mixing those up. Intubations, I'm helping with the medications for intubation, drawing those up, and then ensuring our patients have appropriate post intubations, helping the nurses with getting those medications titrated to an appropriate level of sedation. And then in terms of Less emergent things. I do a lot with our medication reconciliation program. So, ensuring that we have an accurate medication list for our patients who are being admitted. And then I help a lot with discharge prescriptions and transitions of care. So, we have it set up to really, if an outpatient pharmacy calls with an issue with a prescription that they need to clarify with the doctor, that call usually comes to me first and I triage it. 90% of the time, it's something that I can get sorted out without having to get the physician involved and then obviously escalating if it needs to be. I also do all of the culture follow up for the emergency department. So let's
Oh,
say somebody comes in with a UTI, they're discharged on antibiotics, takes 3 to 5 days for their urine culture to come. I'm reviewing those urine cultures, making sure that their antibiotic is appropriate and getting it changed to a different antibiotic if not. And then I get a lot of questions from the doctors and the nurses. The doctors, a lot of times, are asking me to review home medications to determine if any home medications could have contributed to the patient's presentation to the emergency
yeah.
department. If a patient falls at home, okay, are we on a lot of over sedating medications at home? Do we have polypharmacy going on? And the nurses, I get a lot of questions about IV compatibility, medication administration. I also do a lot of chart review, making sure that if there's anything to be intervened on, does the patient have a electrolyte that's low that needs to be repleted? Just different things like that. A lot of antibiotic dosing. So, all of our vancomycin, other antibiotics, do a lot with that. My big area of research the past year has been about our care for rabies post exposure prophylaxis patients, which is very
Interesting.
random, but it's a fascination of mine, rabies is. And so we have been able to reduce our emergency department utilization because the pharmacists have taken over instead of patients coming back to the emergency department for subsequent vaccine doses. We now schedule them for our outpatient infusion therapy clinic. So we've been able to save a lot of emergency department visits that way. So I just do all sorts of things.
Yes, you do. And I feel like that path sort of mirrors what we do, right? There's things
Yes.
that people assume that we do.
Right.
I would assume that you do medication reconciliation. I would not assume that you're involved in cultures, for example. So that's
Right.
very cool. Rabies is also a thing I never would have had in my medical record.
For sure. For sure. No
Oh, no,
rabies.
thank
Rabies
you.
is bad.
I want to give you an example this weekend where I felt like I was on shift and there was like a whole medication plan for a patient. The patient was going to go home with a Medrol dose pack.
Okay.
And then the patient said, I'm allergic to prednisone.
Okay.
That felt like a really good opportunity for us to pull in the emergency department pharmacist and collaborate on what would go well for that patient. So, can you
Yes.
give other examples like that?
Yeah, absolutely. That is something we run into a lot of times is allergies. And like I said,
Yeah.
I get a lot of questions from the doctors. Okay, the patient's allergic to this. What do I do instead? And I'm very hands on in those situations, talking to the patients about, okay, when did the reaction happen? What kind of reaction did you have? What other medications have you tolerated before? And helping develop care plans in that way. We'll also run into a lot of situations with insurance. A lot of times, we may be planning and have a really great plan to send a patient out on one medication, and then it comes up insurance isn't going to cover this medication, or insurance requires a prior authorization. So, helping collaborate, figure out alternatives that will be covered by insurance or exploring other options like coupon cards or cash pay programs to help with that.
Think what I need everybody listening to hear from that is that it's not just PT that runs into insurance barriers with discharge, right? We make a
For sure.
recommendation. We want this patient to go to rehab, insurance. No, we want this
Mhm.
patient to get outpatient therapy. They have to have pre authorization, or the home health agency can't take the patient because they're not in network. So
Right.
I guess it's disheartening and also heartening to
Yes.
know that other professionals are running into those same discharge barriers. But I think that's really helpful for us to see that the discharge barriers are not just placement related.
Right. For sure.
Okay, my next question for you really is what are the best ways that you would recommend for a physical therapist to collaborate with pharmacists? Because I feel like There are a few examples. I don't know if you're familiar with the Gap Care study, which is about older adults and falls. So they come to the emergency department for falls. And the two interventions in this study are a pharmacist and a physical therapist.
Oh,
It's like you talked about reconciling medications, looking at them to see if they're contributors. What other opportunities can you see for us to work together?
that's a very good question. And honestly, I think that there can be so many. And I think that a lot of times we're points of accessing care. And so I think just whenever a patient alerts you of something, if it's anything to do with medications, absolutely loop in the emergency medicine pharmacist and let them know if there's ever anything you have concerns about, because I may go to the patient and talk to them and they may tell me one thing. And then they may think of something while they're talking with the emergency department physical therapist that didn't even come up in our conversation,
100%.
but may be relevant. So I think just absolutely communicating and looping in friends when necessary.
I think that's a really good point because I had a patient recently who had an addiction to a supplement that is
Okay.
opioid related supplement.
Yes.
You might know what I'm talking
Yes.
about.
I
I don't
think I can guess.
mention it. Yeah, I don't want to mention it just
Yeah,
to not give too many details
for
about this
sure.
particular patient. But I find, especially in Colorado, the rise of substance use,
Yes.
and the rise of supplement use are both also confounding variables for us. So, is that something else we can bring to you?
Yeah, absolutely. That's something that we can talk to the emergency medicine provider about and have conversations with the patient about dangers of said supplements, and especially sometimes supplements can be adulterated. And so, talking about treatment options for addictions to those substances and looping in our friends in case management and social work if the patient needs access to rehabilitation therapy. It takes a team, that's for sure.
This is probably a delicate question, but I feel like you work really hand in hand with emergency physicians. There are times when obviously prescribing medications is outside of my scope of practice, but the impact of those medications impacts my scope of practice.
Right.
So, for example, I had a patient who was there for dizziness, likely a vestibular disorder.
Yeah.
And while they were waiting for us to come to the bedside to evaluate the patient, they had medicated the patient. When I went in to see the patient, I sat her up. She couldn't sit upright. She couldn't visually track, like was falling to one side. I had a real concern that perhaps I needed to call a stroke alert for this patient. Went to talk to the physician, and he said, "Oh no, I just gave her droperidol." And I was like, "Buddy, she can't hold her head up anymore." And he said, "Well, she's not dizzy now, is she?" And I just felt like, no, she was not dizzy, but she had to hold
Right.
overnight because she was so sedated, right? Because she
Sedated.
couldn't part. So, what would you suggest is the best way to have conversations with physicians about how certain medications might impact our evaluations? Or is there a polite way to say, hey, can we talk to the ED pharmacist about alternatives that might allow this patient to participate?
Yeah, absolutely. I would say that from my scope of view, I'm always willing to have a conversation with anybody, any member of the care team. I try and establish relationships with anyone. So that way they know that if there's an issue that comes up and maybe they're not comfortable talking to the physician about it, that they can come and talk to me about it and I'll assess. And I would say that I'm very lucky. I've got very great physicians that I work with, and they have a lot of trust in me. And so, usually, if I bring something up to the majority of them, they're pretty good about second thinking, like, hey, if Sarah's saying something to me about this, I should probably take a step back and reevaluate what I'm doing. And I think a lot of times, if it's a physician that I'm a little bit more hesitant about, I'll be like, hey, I saw you ordered this. Tell me your thinking behind that.
I like
Help
that.
educate me, and then sometimes that leads to, well, have you thought about it this way? And then I help educate them.
That is so graceful. I really like that. That makes a lot of sense. I think too, there are just so many medications that have impacts on mobility, right? Whether our patient is now orthostatic, whether they received meclizine when it probably wasn't the right medication for them. if they had something like Reglan that might be making them feel a little gross. Or the other thing that I see a lot of are patients that are newly on antidepressants that are now causing dizziness symptoms
Yes.
or pain medications that are driving issues with patients too. What do you think is the biggest things that we should be on the lookout for when we're receiving a history from patients about their medications?
Yeah, absolutely. I would say, especially when multiple agents are used together from sedating drug classes, I feel like that's typically where I see the most problems. When a patient's on an opioid and a benzo and a tricyclic antidepressant and an SSRI, that a lot of times is just room for a lot of bad news. And then you bring in, they've got AFib, they're on Eliquis, then they're at risk of falling and hitting their head and a bleed. So I think just a lot of times that's a red flag. And then also when the patient tends to not know a lot about their medications, I feel like the less they know about their medications, the more concerned I am about looking into what medications are they on. They're getting multiple things from different pharmacies. They're getting multiple medications from different doctors, outpatient.
Yes.
Yes.
And that's a great question because oftentimes I think I'm guilty of this. I'll say, hey, do you know what medications you're taking? And they'll say, well, I take three, but I don't know what they are. I just pills, I don't know. And usually for me, that's like an automatic referral to occupational therapy because
Yes.
those patients, their health literacy is not maybe what it should be. Like maybe they're making medication errors, their ADL setup around their medications is a concern. But is there a way for us to find out what they're taking if it's not documented? How do you start with the
Yeah.
patient like that?
Absolutely. So I'm very lucky, and I feel like this is becoming more common at most hospitals for the EMR to be integrated with some sort of system to input what patients have been filling outpatient. So
Okay.
we've got a program that basically it's based off of insurance claims. So typically I can see anything that the patient has gotten filled in the past year. Now, sometimes that gets a little tricky. Occasionally, we'll have a pharmacy that doesn't report to that system, or like VA patients, their medications don't report to that system. So then I may go have to do a little bit more digging. But I would say probably for 80% of our patients, I have pretty good access to see what they filled in the past year. And then a lot of times, if a patient doesn't know what they're taking, and especially if it's during business hours, I'll ask, okay, you don't know what you're taking. What pharmacy do you fill at? And usually they know what pharmacy they'll fill at. And then that way I can call, have a conversation with the outpatient pharmacist and get a better idea that way. And sometimes that leads to a lot of interesting conversations because the outpatient pharmacist may alert me of things that they've been concerned about with the patient that they just haven't really had the chance to communicate to anyone. And then I can communicate that to the ED physicians.
That's amazing. So is that a thing we can come to you and say, hey, like the patient doesn't know what they're taking. There's nothing in the chart. They say they fill their prescriptions here. Is that something I can come to the ED pharmacist and ask? Can you look into that?
Absolutely. That's something that I'm always more than happy to do. And then if I'm slammed and pretty busy, I'm very fortunate to have a pharmacy technician to help me out with medication reconciliation as well.
Yeah.
And so she's a great team member as well in that.
Okay. One other thing that I talk to EDPTs a lot about is when they integrate into the emergency department, like to really shift the culture and make sure that the right patient is seeing the right person at the right time. You know that there are a lot of pathways and algorithms in the ED, which is
Yes.
why you're at the bedside for intubations, right? That's in a pathway somewhere. I feel like there are some really good opportunities for physical therapists and pharmacists to partner together on certain pathways, whether that's a fall pathway, a dizziness pathway, a chronic pain pathway, an acute pain pathway. What do you think about that?
I think that is great. And most I
Right.
preach a lot. And I'll have times where providers will ask me, okay, what's the best pain medication to prescribe for this? And I'm like, these are things that we can do temporarily. But
Yes.
long term, they need an outpatient referral to physical therapy. They need to get their root cause of the pain evaluated. It's not just about medications. Medications are great in the proper place, but there's more to it than that. And so I think, especially for acute pain, and then I don't know how much honestly, and this is a lack of knowledge for me, but I know in the ICU when I practiced as a pharmacist, our intubated patient range of motion, helping with that even while they're still on the vent is one of the things our physical therapist did. I don't know if that's something you all do in the emergency department, to be honest, but I think it would be wonderful even working together on those intubated patients in the emergency department. Range of motion even sooner, as soon as we can start working on that when appropriate, I think is great. Like you said, our patients who present with dizziness, all sorts of opportunities.
Yeah, and when those folks get Valium or they get methylzine, or even like phentermine, like those things can impact our ability to
Yes,
evaluate the patient. But also, on the other hand, if the patient can't stop vomiting, I need your help.
for
Like,
sure.
I can't fix that. I definitely need your help with that. I think the other
Yes.
thing that I see a lot is, and the way that I talk to physicians about it is, I'm not making medication recommendations, right? But I am evaluating the patient. So, say a patient comes in with acute low back pain and I go in and evaluate the patient. I have done that physical evaluation. And I feel like it's really hard for the physician to make an appropriate medication recommendation without my findings. So
Yes.
there are times when the physician will be like, I can give them a muscle relaxer. But I think it's my job to say, hey, there's not muscle spasm, there's not tension. This appears to be very neurogenic.
Yes.
And I think that guides that medication process more helpfully. And that I think is another example of that partnership.
For
So
sure.
is there the right pain medication for the right type of pain that they're having? And they can't do that part of their job without knowing what we found in that exam. So I love that
Absolutely.
partnership too. Okay, wonderful. Tell me, one of the things that I have here listed is that you are the coolest pharmacist around. And I want to know why. Tell me what makes you exceptional at your job.
I feel as humans, it's always hard to brag on ourselves.
But I'm asking you to.
Yeah. I feel like I'm just really proud of, I'm still a relatively new practitioner. I graduated from pharmacy school 5 years ago now, but I'm just so proud of the work I've been able to do in that 5 years. And I'm really proud of the relationships I've established with my providers and my nurses that give them the trust in me to do my job and do my job well and really practice at the top of my scope. I was staffing in the main pharmacy actually this past weekend, and I got a call from the emergency department that they needed me up there, that there was a young patient who had coded. And so I ran up there right away and I come in, I assess the situation. No medications have been given yet. So I bust open the crash cart, and before I could grab any medications, they were doing a pulse check. And I looked on the monitor and saw that the patient was in BFib. And so I immediately announced to the team, I'm like, y'all, that's a shockable rhythm. We need to shock that. And so we were able to quickly shock the rhythm. And the code did continue on. And we ended up actually having to shock the patient 5 times. But finally we got them back, and now they've had a really good outcome, have been able to be extubated. And in emergency medicine, it can be hard. You win some and you lose some, but the wins like that make me really proud. And one of the nurse practitioners that was in the code came up to me afterwards and she hugged me and she was like, Sarah, thank you for what you do, because when you're in the room, I know and I trust that the patient is going to get the good care that they need. And I teared up a little bit and hugged her and said, thank you. I really needed to hear that today. But I think those wins of being sure that guidelines are being followed and the patient gets the appropriate medications that they need. We got them loaded up with the appropriate antiarrhythmics. And I think just really good wins like that make me proud of what I get to do.
I love that because I also feel like when you're an emergency pharmacist, just like when you're an emergency physical therapist, you don't get to build that long-term relationship with with your patients. And
Yeah,
I think for some people that doesn't appeal to them. They went into healthcare to build long-term relationships like a community pharmacist might have.
right.
So I love that you're able to take those wins and really be present with your patients and be part of the team.
For sure.
I love that. So one thing that I ask everybody at the end of the podcast is, what is your top book scope tip? And it doesn't matter if it's about PT, if it's about pharmacy, if it's about healthcare in general. I want to know what your top of scope tip is for any practitioner.
Absolutely. So, one thing that I always tell my students and my residents is to always do your best to treat every patient like they're your grandma. Because if you approach your practice that way, as to making sure every patient gets the care that you would want your grandma to get if she were in the hospital, you're going to be practicing at the top of your scope and you're going to be taking the best care of your patients that you can be. So, that's what I tell every learner. And that is what I would say my top of scope tip is.
I love it. Thank you so much for being on the podcast today. It was amazing to learn from you, and I am definitely going to start seeking out more opportunities for collaboration. Thank you so much.
Absolutely. I love that. Thank you.
And for anybody who's looking for more content on emergency department physical therapy, you can check out our YouTube. You can check out our Top of Scope summits that are available for replay. And you can always get the book, the Top of Scope Handbook for Emergency Department Physical Therapists on Amazon. Thank you.